So let's get started. Let's dive into the comprehensive model for mental health access and service use. Firstly, let's acknowledge everybody who's worked on this model. It's not just me. If you want to rethink healthcare provision, you need some excellent minds in the field. And you can see the collaborators here. Tom is also here with me today to support the technical part. So let's hope we don't need him right now, but he will be here as well. The comma model has been published in Internet Interventions. The paper can be found here through the link, and you can read through it after the session as well. So during this talk, I would like to, of course, present the comma model and its components, so you can easily use it yourself afterwards. But first, I will start with introducing some recent developments in the field which have inspired the model, because it has been built on some transformations in the field that we feel call for a new process model. And in the end, I will have a bit of time to reflect on practice implementation and future steps with the comma model. But as I said, first, let's have a look at some developments that call for new process models. During the past years, we've seen that mental health care systems struggle to provide timely and appropriate access to care. We're seeing that on a global level. It's not just in Europe, in the States, or in other countries, but it's a general evolution, unfortunately. But despite these major challenges we're facing, there are also several opportunities that help us to critically analyze how we provide services today and that help us to improve our service provision for those who need it. So comma aims to provide a substantive process model by building on three main developments. Firstly, relating to the organization of care. Secondly, to the allocation of healthcare services. And finally, also to the digital transformation of care. So in terms of the organization of care, we're seeing that the narrative for treatments for mental illness is shifting. While we are used to having these traditional siloed care with institutional care, psychotherapy, and pharmaceutical treatments, we're now trying to open up the borders and blending mental health within general medicine at a system level. So breaking through the silos. And we're seeing that with these integrated care models who've been proposed. The first one that was a great inspiration was the collaborative care model, which adopts patient-centered care delivered by a mental health team and in primary care services. Secondly, the WHO has also proposed the model for optimal mental health care, which also advocates for this integrated primary care, but also goes further and emphasizes the importance of informal care and community-based mental health approaches. Finally, also to briefly acknowledge that the structure of societies also affects population health. A look at health from an individual perspective, but the way we organize our society also influences health and also could provide interventions and supportive means to help us deal with mental health care. Secondly, the allocation of healthcare services is also really important, and Rick Wood has provided a good model to look at that, which is a model of help seeking. And in that case, they discuss that help seeking often starts with the awareness of a need for help. Then certain intentions start to develop and they try to identify help sources. And a third step can be actually approaching formal or informal healthcare. But as you can see, a patient, at that point, probably not a patient yet, but an individual can exit this sort of model at any point, because we see that awareness of help might be there, but actually engaging, that's a smaller group. And help seeking can result in accessing self-help resources, informal care, or formal care. And the access to formal care can sometimes be sort of gatekept by professionals. So we need professional referral, but also here we're seeing more and more evolution towards options for self-referral as well. Once we have been in contact with a healthcare service, there's still sort of a sequencing that happens because there's multiple levels of intensity in mental health care. And they can be sequenced according to the stepped care model, where we focus on providing the least intensive or restrictive intervention option, which is expected to provide health gain. So the easiest accessible option at first, and then when it's needed, people can step up to higher levels of more intense care. We've also got matched care approaches where they really try to find a good fit between an intervention and the patient, so we match them. And now we also see models with sequential stepping with stratified elements where we use the stepped care as a basis, but also when this is needed, high complexity cases can be triaged directly to high intensity services. So this is the second area where we see development. So we had the organization and now we have allocation of healthcare services. But of course, the third big one, which we can't ignore over the last years, is related to digital transformation of care. The past decades, and also a pandemic slightly helps in this case, we're seeing a lot more digital transformation of care, more digital services being offered. And these digital services can be linked to the allocation of healthcare services, where we're seeing the rise of precision medicine, also in the field of mental health, where we want to sort of build on the heterogeneity within a person and based on that, provide services that really match and that are expected to help and also predict what might help these individuals. And there we can use a lot of different sources of information, for example, using digital phenotyping, which bases itself on the digital footprints that a person has. We can use large language models in this process, clinical decision support analytics, and so on. And there's also AI-based flow management tools, which can support healthcare organization, where we can forecast patient volumes and resource planning and management, so more of a technical matter. But this is not the evolution that we've seen most in clinical practice. Of course, the digital transformation is most visible when it comes to interventions. There's been a lot of more digital approaches, both in diagnostics and in treatment processes, where we're seeing models of blended or hybrid care, where we combine synchronous face-to-face or at times also telehealth contact with digital interventions, which are offered asynchronously, so not direct in a live matter, but through apps, for example. But implementations vary greatly in content. This can be everything from apps to wearables to VR, and they can also target many different problems or challenges that a person might face. An alternative model that has also been proposed is a digital clinic model of care, which can complement collaborative care models and actually uses a combination of telehealth and digital intervention. So everything is offered in a digital way. And there's a digital navigator who can guide the processes. And a digital navigator is an individual who's got some additional training, some specialist training in the field of technology. And they can help with selecting the right devices, providing follow-up using digital tools, but also troubleshooting, which can be needed both for clinicians as well as for patients. So the field is changing. During the last years, there have been a lot of evolutions, a lot of changes that we are seeing. And we know that many of them are effective. For example, community care, self-help, digital interventions, they have been shown to be effective. And these approaches are also good ways to reduce pressure on formal healthcare systems. And even in some cases, for example, in Germany, we see that legislation is not lagging behind, but is actually setting the scene, is building a good stage where we can use these digital tools as a complementary way to our usual mental health services. So even the legislation and the technical aspects can be ready for implementation. However, we are, of course, not seeing all these interventions being implemented at this time already. There are several challenges in implementations that we're also seeing at this point. Mental health systems have the tendencies to be very complex, rigid, and they're also not equally accessible often, unfortunately. And the WHO has also documented that these approaches, such as community care and self-help, they all struggle with large-scale implementation and uptake. So the models have been there, the theory and the evidence is there, but in practice, we're not seeing enough of it. And it's often linked to the fact that digital mental health is seen as a novelty or specialist domain. And also the same with community care. So it's not structurally integrated in existing care pathways and an existing process model. So it is seen as something else. And that's something we want to break through with the COMA model. So based on these things that we were observing in the field, we wanted to reorganize how we look at mental health care. So we developed the comprehensive model for mental health access and service use. And it is a process model for collaborative care, leveraging technology, but also considering all these new evolutions we are seeing in the fields and capitalizing on their potential. So it's a flexible framework which can guide aspiring professionals, but also support implementation in the field with good quality workers and good quality interventions, of course. So the COMA model acknowledges current scientific evidence. It also integrates some policy perspectives, and it builds on existing clinical practice. And we aimed to sort of represent the patient journey along a digitally enhanced mental health system. So this is the model in its entirety. And in the next steps, I want to go through the different components and discuss them briefly with you. Of course, everything starts with a certain concern that somebody can have, and this can be individuals themselves, a future patient, perhaps some types of users. They can experience a certain need, but also people in their immediate environment can observe things that cause concern. And such a mental health concerns can prompt a search for formal or informal sources of support. This concern can be remedial, so it can be that you observe a certain problem for which you're searching for a solution, for example, elevated anxiety, but it can also be preventive. We might want to do health promotion, might want to foster our resilience or mitigate stress levels, for example. And of course, this is the best scenario where individuals and their environment experience a need and search for help. But in practice, we see that in some cases, services can also be provided without such a request for help in cases of involuntary treatment or commitment, which is things we try to avoid, but at times we need to make use of. So this mental health concern leads to a help-seeking journey. And as we discussed, based on the Rickwood models, we see that help-seeking can lead to the use of this informal support and accessible resources such as self-help. Help-seeking can also lead to accessing professional interventions and diagnostic services, so actually formal care within our care system. Unfortunately, also after a potentially substantial waiting time, which is also a commonly seen problem. But also important to acknowledge that help-seeking can result in doing nothing, because we see that there's low actual help-seeking in the population. So there's many people who have a problem, but do not consult any of these services, unfortunately. And respect to this, it's also important to reflect on how we view primary care, or what we think is the first point of access to help or to care for our clients or our patients. Because even though we might be embedded in primary care, we're often not the first point of contact, because these days, when people don't feel well, what they start doing is looking online, looking at websites, apps. Some people might even have wearables who indicate that their stress levels are elevated. And they can also often access informal support. They might have talked to teachers previously, or they might have built some network around them that provided some sort of support. I think these days also ChatGPT is a very common first point of contact for care. We can think about what we like, but it might be the case. So when going back, one of the first options in the model that patients can or likely access is informal support. And we operationalize this, in line with the model of optimal mental health care by the WHO. And this model is actually a service organization pyramid. And there they propose that the two bottom layers are related to, firstly, self-care and self-help, which is the base of the pyramid, but it's also sort of the side of the pyramid, something that we need to do continuously, even when we're receiving professional care. And the second level is related to this informal care in the community, which is not part of formal care, but it's more accessible. And on top of these two bottom levels, we see that there's formal care, of course. And those are services for people with higher need and are also associated with higher costs. And then we talk about primary care, mental health services, general hospitals or community mental health services, and long-stay facilities. But let's take a step back. We're talking about informal community care. What do we mean by this? These are services and individuals in the community which are not part of the formal health and welfare system, but they're more accessible and they often play a role in providing support. This can be people in the immediate surroundings of users, for example, teachers, but this can also take place in the online or the digital network around individuals, such as online peer support groups. And accessing informal community care, it can happen in a standalone way. Perhaps we're just looking for help and we're finding these types of individuals around it, and this is enough for us to move forward. This often also happens during these prolonged waiting times, which are associated with formal care services. But ideally, formal care is also embedded or linked to a collaborative care approach, where these informal caregivers can also rely on resources from formal care and have referral pathways when this informal care is not enough. The second aspect that is included in informal support is self-care. And the WHO defines self-care as the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and cope with illness and disability. And this can be supported by a health worker or independently. And self-care can include self-management, for example, self-administration, also linked to medication use. It can be linked to self-testing and self-awareness, which includes self-help. So that's how the WHO looks at self-care. When we look at the field of psychology, we more often talk about self-help, actually looking for help yourself. So self-help can be defined as providing yourself with what you need to help you solve a certain problem and a habit or learn a skill. And common goals of self-help are indeed like finding information about your illness, about potential treatment pathways as well. It can be linked to self-monitoring, so accessing mood monitoring, monitoring your stress levels over time, and also doing exercises, think about meditation, relaxation, and so on. Self-help has also been shown to be effective. And in recent years, it has mostly shifted online, while self-care used to be based on books and written materials, so bibliotherapy. It has, during the past year, shifted to the internet, to websites, social media platforms, and other digital platforms. But I think right now, self-help is also making a very large shift to AI models, where people try to look for help and information from such chatbots or language models that can help them provide answers to their questions. Self-help, as I said, has been shown to be effective, but there are also several challenges related to self-help. Firstly, there are important cultural differences, which means that an intervention that has been developed to work well, for example, in Belgium, might not work well in Namibia or in another country, because there's differences in how people like to receive care and how they view certain evidence-based healthcare options. So we need some sort of cultural adaptation which can reduce scalability, which is important to keep in mind when designing self-help interventions. Secondly, and this is a problem which we've been discussing, I think, in the digital mental health field for a while, retention of self-help is very low. We've all seen graphs passing by where we start with very high levels of people downloading an app and starting with good hopes and interests in using a self-help approach. But after a couple of days, reductions are very large, and after a month, people generally stop using it. So we see that retention is a very, very big challenge. And sometimes this has been, people have tried to turn it around by providing guided self-help. So a professional can help them support and call and see, what are you doing right now? Is it working for you? Do you need any adjustments? But also there's an importance of app design and also which goals that you're setting for yourself. Because very long-term retention might also not always be needed. Perhaps after using the application for a week or for a bit longer and learning, getting the information that you need and learning certain tricks to help you cope with some challenges might be enough. So maybe you also don't need to go for very long-term engagement. It depends on what a person wants to reach. A third challenge is when looking for self-help, we come across a very large number of apps or websites. There's a lot of information available on the internet, and it's not always very evidence-based. So we need to try to find our way in this jungle of applications and information and websites. And finally, recently, we're also seeing a lot of concerns relating to generative AI, because we see that it is able to interact in a human-like manner, but of course, we shouldn't view it as a good healthcare professional, because it often tries to confirm your thoughts. And there's like the sycophancy, which is a big problem, where they try to just strengthen your thought patterns, while good mental health counseling also requires to challenge some thoughts at some time. So AI can be a resource at times, but it can also be a great challenge and related to some difficulties. So this is sort of the first option for healthcare that people encounter in the COMMA model. So it's the informal support consisting of community resources, self-help, self-care. The next steps that they can encounter in the COMMA model are part of formal healthcare services. So there is a professional involved to some extent. And it's also important to bear in mind that many, if not all, of the professional psychosocial skills that we've learned during our training apply to both technology-enhanced and face-to-face care. However, in addition, the field would really benefit from incorporating digital skills in the curricula in professional training, because we are now seeing that many professionals in the field are struggling with adopting digital resources because they've simply not learned how to use them effectively in combination with other services, or how to look at their quality. As I said, luckily, we already have a lot of professional skills which we can use face-to-face and online. And some we use exactly in the same way. Showing empathy, we can do that face-to-face by paraphrasing and by mirroring emotions. And online, when we do online consultations, for example, we do it in the same way. In some cases, we might need to adjust our processes a little bit. For example, we should adapt our communication to the target group, which we do face-to-face by using appropriate and inclusive vocabulary, by adjusting what we say and how we say it. While digitally, we also do that by using age-appropriate applications, or adapting application or digital offers for certain people with language disabilities or other preferences. So their tailoring happens a bit in a different way. Same for confidentiality and ethics. face-to-face, we handle our confidential information with care, of course, that's what we always do. But online, it also requires that we check privacy conditions of an application, for example. So all these skills remain important, but might result in a little bit of tweaking of how we use this skill. So the first aspect of professional services that a person might encounter is a diagnostic process. So they can receive diagnostic assessments consisting of interviews, screening instruments, questionnaires, potentially supplementary research such as certain tasks or physical examinations. And all these tasks or activities that we do aim to provide insights into the functioning of an individual, into their challenges, into certain strengths they might have, into how their life is going right now. Additionally, this diagnostic process can, of course, lead to a formal diagnosis. However, that is not necessarily the case. We also see more and more criticism regarding formal diagnostic classifications because there's a lot of heterogeneity. One depression is not the same as another sort of depression. There's also dynamic changes within individuals. Pre-clinical stages could also benefit from receiving intervention. So there's a lot of heterogeneity, which we cannot account for in formal diagnostic systems. And in this case, it's important also to keep that in mind because technology could here help us a little bit. When we move forward and we adopt precision mental health in a more elaborate way, because right now it's something that is often proposed and researched, but it hasn't entirely made the transition to clinical practice, of course. But we can do little things that can help us in the diagnostic process by using technology. We can, for example, use contextualized assessment and not limit all of our assessment procedures to our therapist's office, so to say, but also measure outside when a person is struggling or facing real challenges. And we could use approaches such as digital phenotyping or capitalizing on all the data that a person is already collecting or is leaving traces of online. The diagnostic process can take place in multiple modalities, of course. Traditionally, how we do it is we have a face-to-face diagnostic process where we have one or more visits to a professional, we complete some interviews, we do some diagnostic assessments, and so on. And based on that face-to-face contact, we can determine what the problem is and potentially provide a diagnosis. The challenge that we see there is that conclusions can be hampered by the fact that we're doing these measurements one time and in this fairly artificial setting. We know that measuring something in a doctor's office is not always the same as measuring this concept in real life. So therefore, technology can be useful. And diagnostics can also take place entirely online or entirely remote. And this can account for problems relating to this one-shot measurement, but also relating to mobility or access to care. However, this clearly comes with additional dangers. We need to pay careful attention to ethical, methodological, and technical issues. We also need to collect more evidence on how these online assessments work and how effective they are in detecting certain problems. And as I said, we are still in need of a lot more training for professionals to effectively use online screening tools and online assessment approaches. So here, of course, a solution that can work and amplify sort of the benefits that we have with face-to-face care and with online care is blended diagnostics, where we can use a multimodal approach, which can include practitioner observations, because these observations can be more difficult online, but also use digital assessments to provide more fine-grained insights. And there, of course, we still need to take care of our digital components and make sure that they are designed with good ethics, methodological quality, and so on. But this could sort of work on the drawbacks that each other approach might have. So after a diagnostic assessment, potentially, but potentially also when a person contacts a service directly based on their problem definition, it's relevant to do some sort of additional assessments. There are some characteristics that are very relevant when selecting a suitable treatment offer. And the first is to assess the knowledge that a patient can have. We want to assess and promote health literacy. We want to falsify potential incorrect information that an individual might have. And these days, with social media and AI models, we see that some misinformation is really amplified and is reaching a lot more people. And this can affect their knowledge and their willingness also to get treatment or assess or use certain treatment approaches. We also want to have a look at their skills, because certain skills can be needed to make use of a proposed treatment, for example, digital skills. And we also want to have a look at beliefs and attitudes, which are generally also built on these knowledge and these skills that will influence willingness to use technology in this context. So once we know this information, we've got a bit more background information, this will really help us to personalize services, which can in turn help us to get successful outcomes with these patients. So therefore, there are some good practices that we would like to promote, which is firstly reviewing the knowledge, skills, and attitudes that users have. During an intake process, we want to see what they believe depression is, for example, of what they think about treatments. We might also want to use a health literacy questionnaire to see whether they can really comprehend and use mental health information. After reviewing the knowledge, it can be relevant to increase knowledge and skills. When we detect potential misinformation from the hashtag ADHD or the hashtag autism on TikTok, for example, which has a lot of misinformation, then we want to increase knowledge and skills. Thirdly, we want to assess user preferences to tailor our professional services. And in this respect, I think it's really relevant to assess what an individual has already done, not necessarily in case of formal care, but also their informal and self-help searches can lead to certain resources that were proved to be very useful for this patient in the past that you can continue to use. Or it might point to certain negative experiences with certain technologies that you might not want to use with this client. And of course, fourthly, we always want to consider equity and inclusion in the approach. And we want to tailor our communication to a client's health, digital, or other skills. And we want to provide support. If we propose to use a digital technology, we or some team members, such as a digital navigator, for example, want to provide some help with installing and testing applications. So this is sort of our influx model, how we think that people can access mental health services, so the top side of the model, of the COMA model. And the remainder consists of preparing and executing interventions. So when we want to determine a suitable service, we want to do that, first of all, together with a client and a professional. I think that's also where our digital revolution has come in handy, because it has opened up information to patients. Patients get a lot more information about themselves and about all sorts of mental health conditions. And they can also be a more active participant in selecting interventions. And we want to do that in line with evidence-based practice. When looking at a specific mental health service, we can propose this based on our top of the model at the request for help. We can base this on possible results of a diagnostic assessment, which can also include problem complexity or severity when we look at stepped care or intensity-based service allocation. And we want to use the information about the knowledge, skills, and attitudes that we have collected. And as I mentioned previously, it's important to take into account that different referral pathways exist. There are different ways how people access mental health services. And it can be facilitated by professionals, or it can be through self-referral, and potentially supported by AI. And it's also good to have these different access ways because they've shown to be complementary in the healthcare system, and they can serve slightly different people with different needs. So these multiple access ways are very useful. So we want to, of course, offer an evidence-based mental health service. And evidence-based practice can be defined as the conscientious, explicit, and judicious use of current best practice in making decisions about the care of individual patients. So we want to provide the intervention that is supported by research that we know is likely to be effective in this patient. It will not always be the case, but this is the best option we have. And we can provide these evidence-based mental health services in a matched care or stepped care approach. But of course, the mental health system in which we operate can limit available intervention options. For example, in the stepped care, we start with the least intense option. In digital clinics, we don't have a face-to-face offer, and so on. So there will be limits, of course, in applying this evidence-based practice. Roughly 4 categories of interventions can be offered. So we can look at online interventions, blended face-to-face or referral. I will go into that in a minute. But I also want to note that COMA is operationalized as an individual patient journey, but of course, interventions don't need to be individual. As I said, based on the social determinants of health, it definitely can benefit society if we also have interventions targeting schools or community. And on an individual level, family-focused interventions have also proven very valuable to also treat the system around patients. So the first intervention option that we can consider are online interventions. So a service that is offered entirely online. Examples include online consultations, for example, video conferencing software being used to facilitate consultations between a therapist and their patients. It has been shown to be an effective and viable alternative, but apparently it's not very sexy to research online consultations. So in terms of digital mental health research, this one is a bit lacking behind. Something that has been more extensively researched or online programs, for example, cognitive behavioral programs, have been shown to be very effective and as effective as face-to-face CBT for many disorders. And in general, internet-delivered treatments have been proposed to be able to reduce waiting times, increase patient recovery, and potentially also reduce costs with similar treatment effectiveness. So definitely a viable option. However, of course, a very viable option as well, and especially for a first contact, it might be better also to start face-to-face when you can. So mental health services can be offered entirely face-to-face, which can be specialist residential facilities, or it can be ambulatory services or community care to provide further care or support or more low-level interventions. So face-to-face, definitely still a very evidence-based and very good option of providing care. Finally, we can, of course, also blend the two. So a blended service refers to combining these face-to-face consultations and online or digital intervention. And it's hard to give effectiveness rates or examples here because it can literally be pretty much anything. We see that in inpatient treatment, this often takes the form of a digital intervention for aftercare, but we can also combine face-to-face counseling with, for example, online psychoeducation, breathing exercises using several types of technology, playing serious games with children to also, for example, support learning the concepts that you've discussed in a session, and so on. But it can take many different shapes and forms, but there's also been quite a lot of research that can support this, although it's harder to measure, of course, this less controlled treatment option, perhaps. Finally, we, of course, need to make sure that we have the necessary interventions that match the needs of our patients. Sometimes a request for help simply will not align with what this organization or this help system has got to offer. And in this case, we want to refer clients to other actors. And in this case, it's really important to have good knowledge of the services that are available in the region, because when we provide online care, we often forget or we think that we can provide care to anybody in the world, but it's always good to have knowledge of their practical system, because when crises exist or when we want to refer people, we need to know what options are available in their vicinity. And also not the scope of this model, but important to keep in mind that complementary pharmacological treatments can also be beneficial for some patients. Once we've decided to go for an online or blended option, we need to select technologies and see how we deliver the intervention. When selecting a technology, there's a lot of factors that can play a role. Firstly, of course, as I said, the evidence base is really important, but we also need to look at availability of technology or the internet for clients. We need to look at digital skills of clients and care providers. We can consider pricing. We can also consider the preferences that individuals might have. So selecting technology based on all these potential parameters can be supported by the professional themselves, but they can receive additional support by a digital navigator, potentially, who's got more background in this field. Or AI recommender systems are also being used to help guide this process, this important process. When we select a technology, there's, of course, multiple things to select. It's not just one thing. And if we can sort of think of it as a staged process, where we first select an appropriate technological modality. If we look at an example, if we want to implement a relaxation intervention to a blended offer, we can select extended reality as a potential way how we can deliver relaxation. Then we can select the hardware, the device that we want to use. In this case, it can be a comfortable VR headset, but it can also be an affordable smartphone, which is something that everybody already has and is a lot more easy to implement, but might have some different qualities. And once we know the hardware, we select a certain software, which can be an affordable application with a proper privacy policy. But again, we've got multiple options in a specific software or specific application that we can select and that will meet the needs of our patients. Of course, once we've selected what we're going to do based on all the information that we have, we can deliver the intervention and we can collaboratively address the needs of the patient. And in this case, follow-up will be really relevant. It's important to collectively determine the goals with your patient, but also discuss the progress that he or she or them is making. This can facilitate patient empowerment and also allows to change a treatment plan when needed. Follow-up is always important in face-to-face blended or online care, but it can sometimes require some additional attention when we do remote treatments, because when it goes wrong, it might not be immediately visible when the contact is purely online. So during and after service delivery, we want to follow up on complaints and on processes and experiences. So continuous symptom monitoring is essential to detect and potentially reserve negative treatment trends who can always occur. So firstly, we can measure complaints. For example, is there any symptom change? Have the goals that we've set been achieved? And we can measure this using patient-reported outcomes or PROMs, which measure the outcomes from the client perspective by the clients or sometimes relatives. When a client is not available, we want to do multiple measurement points so we can measure changes, and ideally it should also be linked to the electronic patient record so we can document these changes and look at them when we need to. So examples can be questionnaires, but we can also use technology to support this, where we can implement continuous assessments of evolutions or transferal to daily life. For example, by using ecological momentary assessment, which is a technique in which we put an application on a client's phone and they get push notifications to assess current states and current moods. So this can give us a good picture of what is actually happening in daily life. We also want to measure experiences. For example, did you feel actively involved in decision making? This is what we call patient-reported experience measures, which we measure pretty much in the same way, except that we usually do this anonymously because feedback can be sensitive. But collecting this feedback can be really relevant because it can contribute to learning healthcare systems where we can improve experiences for future patients based on all the documentation that we have gained through the years. Once we've provided the offer, we've assessed progress and provided follow-up, we can potentially conclude services. We can see whether there are any additional needs that need to be addressed, which we can go to other, the arrow goes to the top, but we can circle back to any previous step that might be needed, or we can conclude services. And when concluding services, it can also be relevant to facilitate access to additional resources. As I said, in inpatient care, digital interventions are often used in an aftercare program. So providing digital tools or booster sessions can definitely be relevant to maintain the functioning of the individual. So this is what the entire COMMA model looks like. So I've gone through the different steps that we believe would contribute to good care and needs to get some attention in implementation and in mental health care. But let's have a look at what this could mean in practice. So as I said, it is a structured approach, but it's also important that it's a flexible approach. It is sort of shown as a linear thing, but it's not. We can circle back, we can go back to certain interventions when needed. And we basically just want to provide some guidance to healthcare systems, professionals and trainees in looking at help-seeking processes and shaping healthcare, and provide a good framework to start from, because it's not an end point. We see it more as a starting point. And it's also important that COMMA does not operate in isolation. It complements technological standards. I've briefly hinted to it, but of course the technology we use need to be secure. So in terms of privacy, equity, interoperability, there's important technical standards that we would like the technology that we use to meet. On the other hand, it should complement a regulatory systems approach. The COMMA model is focused on the content, but we need sort of regulations and payment models and implementation processes to help the model come to life in practice. So it's a conceptual and substantive narrative that needs to be contextualized. It cannot operate in isolation. It needs to be adjusted to the context that is around it, that it is implemented in. And implementation might need to be accompanied by substantial healthcare reforms, where we see that the healthcare system is not ready to adopt community-based or digital approaches. There's additional reforms that need to be met, but it can also be facilitated by existing regulatory and reimbursement schemes. There are several countries who have provided a good context for digital mental health to thrive, but who are currently facing problems with adoption, with professionals' willingness to use digital tools and their knowledge of digital tools. So to conclude, looking at future perspectives for the COMMA model from our perspective, we think that it can help existing services to optimize processes, to implement tools, and to shape how they want to organize their healthcare within their organization, make their own pipelines of how people move through the system. Secondly, it can help educators to prepare future professionals for the field as it is right now. It can help to inform them about the options that they have for treatment, for diagnoses, and also the way that people access care and potential self-help resources. Thirdly, we also hope that we can inspire policymakers to break through siloed funding and to rethink mental health access pathways and how have a different perspective on how healthcare can be provided and can be really looked at from a system, from an informal support network to actually long-term stay facilities. They all need to be linked, and they can amplify each other. Finally, researchers and implementation scientists could develop future iterations of the model. As we said, it's not an endpoint, this model. We hope it can be a starting point for further contextualization, for future iterations, for matching this with technological perspectives, and so on. So that was a very quick 50 minutes walk through the model and how it came to exist and what it builds on. So thank you for your attention, and thank you for joining the webinar.